Good morning and good afternoon to everyone out there, and welcome to the ASCO Global Webinar Series on cancer care experiences and lessons during the COVID-19 pandemic. Our topic today is COVID-19 vaccines and cancer care. Can we move to the next slide? The presentations and answers to questions about COVID-19 presented in these webinars are provided by the American Society of Clinical Oncology for voluntary informational use by providers. This information is not intended to substitute for independent professional judgment of the treating provider in the context of treating an individual patient or developing practice policies and procedures. Next slide. So this time last year, the world essentially came to a standstill as we faced a new enemy in the form of COVID-19 virus. As healthcare professionals, we strove to protect our patients, and specifically within the realm of oncology, we understood that although COVID-19 increased mortality risk among patients being treated for cancer, interrupting services had an equally negative impact. We developed policies and procedures to continue uninterrupted services with maximal protection. After a year of worldwide morbidity, mortality, social distancing, and several lockdowns, we now have hope with the introduction of vaccines to protect our patients. However, as the world is being vaccinated against the COVID-19 virus, we are faced with so many practical questions, the most important of which is what will be the effect on the cancer patient that we are treating today. Today, I have the privilege and honor to address some of those burning questions and touch on public policy issues that have arisen globally with regards to the COVID-19 vaccine with a group of truly global experts who are renowned in their own fields. We have Dr. Najwa Khouri, who comes to us all the way from Jordan, Dr. Danielle Lucy from the USA, Dr. Chite from Kenya, Renette Heidinger from Germany, Professor Mock all the way from Hong Kong, and Lisa all the way from the USA. So without further ado, let's kick off this session with two short, brief talks that will pertain to the COVID-19 vaccination. It's an honor to introduce Professor Danielle Lucy. He is a senior scholar with the O'Neill Institute for National and Global Health Law. He's also an adjunct professor of medicine of infectious diseases at Georgetown University Medical Center. And he has taught at Georgetown for 17 years, focusing on outbreaks and pandemics. And I can't think of a better person who can start off this session and really walk us through the COVID-19 vaccine. Professor Lucy.
Thank you very much, Dr. Dawood, and thank you to the organizers of this conference, ASCO and the Infectious Disease Society of America. As Dr. Dawood mentioned, I'll just show about 5 or 6 slides or covering 4 or 5 minutes. So if I could have the first slide, please. So I'd like to start with the issue about why do COVID vaccines matter now, and I list 3 general reasons. The first is to protect the person who's receiving the vaccine. The second is to protect that person's close contacts, for example, family, friends, co-workers, as well as others who the person may come into close contact with and not even realize it. And third, the individual taking the vaccine will be doing their fair share in terms of protecting the public's health. In other words, many, many people in society. And one other point that I want to emphasize is that each person who takes the vaccine decreases the risk to themselves and to everyone else in their community, in their country, and the world of the virus having the opportunity to mutate in a way that it becomes what we call a variant, particularly a variant of concern. In other words, it can be more transmissible, more severe, or cause some other things that we don't want. So for example, becoming resistant to monoclonal antibodies, which has happened now, we know in the United States recently. Potentially also variants may be able to become partially evasive of antibodies, whether they're from people who have survived a previous infection or people who have been vaccinated. So there's a lot of concern that people who are immunocompromised from whatever reason might have longer infections with this virus and give the virus opportunity to mutate over a longer period of time and eventually mutate in a bad way and become a variant of concern. And I reference this one paper in the New England Journal of Medicine from December 3rd, but there are several other papers now being reported of this phenomenon in immunocompromised persons. Next slide, please. So in the United States, there's currently 3 vaccines that are authorized, not approved, but have received emergency use authorization, or EUA, by the US Food and Drug Administration, by the FDA. Those are the Pfizer Bioentech vaccine, the Moderna vaccine, and the Johnson & Johnson or Janssen vaccines. The Pfizer Bioentech and Moderna are messenger RNA vaccines. They require 2 doses. At least that's what's currently recommended. And for the Pfizer BioNTech, the 2 doses are given 3 weeks apart, and for the Moderna vaccine, 4 weeks apart. The third vaccine that's been approved is the Johnson & Johnson. It's an adenovirus, human adenovirus vector vaccine, and it requires only 1 dose. Next slide, please. In my opinion, I'm certainly not speaking for anyone else, including for the FDA, but in my opinion, the next most likely vaccines that will be requested to be reviewed and then reviewed quickly by the US FDA are the AstraZeneca Oxford University vaccine, which, as you know, uses a chimp or chimpanzee adenovirus vector, and the Novavax vaccine, which uses the spike protein of the virus and a proprietary adjuvant. So there are several different types of vaccines that I've mentioned here: the messenger RNA vaccines, the adenovirus vector vaccines, and a protein only with an adjuvant type vaccine. Next slide, please. So the last type of vaccine that I'd mention is what I call an inactivated whole virus vaccine. Right now, there are none that have been authorized or submitted for review by the FDA. But I think it's very important that there are several such vaccines, inactivated vaccines, that are being used widely in the world. For example, there are 2 vaccines from China, Sinopharm and also Sinovac. In fact, Sinopharm, I think there's one from Beijing and one from Wuhan. And then Sinovac, which is also known as CoronaVac, are inactivated whole virus vaccines. And these vaccines are being used in multiple nations around the world, and were studied in phase 3 studies outside of China, since there's not any appreciable epidemic going on in China. So I list some of the countries here: China, UAE, Bahrain, Pakistan, Indonesia, Brazil, Peru, Chile, and quite a few other countries. Next slide, please. So I'd like to just close with 2 quick references for your background interest. Both of them just came out in the middle of this month. So on March 17th, there's a paper that is not yet peer-reviewed, but it's from the United Kingdom, and it studies and reports on studies of using the Pfizer BioNTech vaccine. And what they report is that in patients with solid cancer malignancies and also hematologic malignancies, that after just 1 dose of the Pfizer BioNTech mRNA vaccine, the antibody response is really quite low. Fortunately, it goes up quite a bit after the 2nd dose. So one interpretation of this data are that patients who have cancer should receive the 2nd dose of an mRNA vaccine as soon as possible, or on the schedule recommended by the companies, either 3 weeks after the 1st dose for Pfizer BioNTech or 4 weeks after the 1st dose for Moderna. Next and last slide, please. This is a paper in Nature Reviews Clinical Oncology. It just came out March 15th, and I'm just presenting it and referring you to it as a reference. It's from a large consortium, US and overseas, in which they give vaccine guidance for patients with cancer who are participating in oncology clinical trials. So here I'd like to stop and turn it over to our next speaker. Thank you very much.
So I'd like to introduce Professor Najwa Khoury. She comes to us all the way from Jordan, and she is an American board certified consultant in pediatrics and infectious disease, and currently serves as a consultant to the Jordan National Center for Security and Crisis Management for control of COVID-19. Professor Najwa.
Thank you. Thank you for inviting me. It's a great honor to be part of this very distinguished panel. Today, I'm going to be addressing the issue of delivery of vaccines. We had just a great presentation by Dr. Lucy, Professor Lucy, about the different vaccines. However, no vaccine is good unless it finds its way to the consumer, to the patient in this case. May I have the next slide, please? Basically, I think it's very important to recognize that these vaccines, all the COVID vaccines that came on the market, really almost came in a rush. And it is the first time in my own history of seeing vaccination that we have so many vaccines come into the market using different technologies to arrive, of course, at a product that will give you a protection. So there were many things, challenges in communication to the patient, to the non-patient, to their contacts, to the public at large, to tell them that they should take these vaccines, keeping in mind that there were many things that were confusing to them, and frequently, this we know, erodes trust in vaccination. One of them, for example, is there were so many kinds that we had to produce at the same time. We introduced, for example, Sinopharm and Pfizer at the same time to many patients, and they didn't know which is which. And how the usefulness, we told them you have to take whatever is available on that day. The second thing is, of course, the subject of the different platforms that were being used. The messenger RNA was used before for Ebola, but never in any vaccines that were for common use. Lastly, of course, they were very expensive, in short supply. Everybody wanted them, these vaccines, and oftentimes we had difficulty prioritizing patients. Low middle income countries had difficulty with supporting the financial aspect, and the medical community really had to counter rumors and misinformation. And in fact, an infodemic, and maybe we can give a whole talk on infodemic, which we won't. Next, please. Now, basically, however, even though these were the shortcomings, there have been some pluses and really opportunities in this outbreak. One of them is, of course, the great amount of global collaboration. And I really would like to mention specifically COVAX, because COVAX really was a way of trying to help developing countries get access to these vaccines. So this is something that was delivered by the WHO along with Gavi and other players. And they had what they called the ACT, which is the Access to COVID Tools Accelerator. And it really depended on giving them vaccines, diagnostics, therapeutics, health system connector. All of them helped the developing countries get access to the vaccine instead of waiting until the end of the line and not getting them. Next, please. However, no vaccine is good enough unless you have a program for it. So you have to find ways. This is the loop that I like to always use to indicate that any link here can go wrong, and then you end up not having the vaccine. And the problem with some, for example, some of these vaccines, they needed -80 freezing, whereas others needed regular refrigeration. So to make a long story short, I'd like you to realize that it is the program that's important. Next, please. And it is not vaccines that prevent disease. This, in fact, was something that we discussed at one time at the London School, and it is vaccination that prevents the disease. So you can talk all you want about the vaccines, unless somebody takes them, then the loop is not closed. Next, please. Now, so I like this. My own son is a violinist, so I know what we're talking about. If you have one bad player in a fantastic orchestra, the whole performance goes wrong. The same thing for immunization. It really has to be, everybody should be at the same level of expertise, of knowledge. Next, please. So for COVID to be controlled, widespread vaccination is the only option. Vaccination, we have to look at everything. Success of vaccination has been demonstrated to be of great help in many other diseases. And I think for that to be accomplished on a global scale, because COVID is a global disease. And if somebody controls it in America and then someone comes in from outside and they are infected, the disease will continue. So coordination, collaboration are essential to the success of this mission. And thank you very much.
Thank you very much. You gave us some things to think about and talk about as we now proceed to our panel discussion with all the panelists online. I see some questions coming in. I would encourage everyone out there to please post those burning questions. You truly have a global panel here who are world renowned, who are going to attempt to answer some of those very important questions. Maybe I can start with you, Lisa. You come to us all the way from USA, and you lead the nursing initiative there in terms of vaccinations. What is the perception of patients there in terms of getting the vaccine, and in terms of hesitancy of some of these patients? Why are they hesitant to get the vaccine? Lisa, you're, I think, muted.
Thank you, Dr. Dawood. I think there are two issues with the vaccines. One is safety and the other is trust. So if I could just talk about each of those a little bit and then put them in the context of a person or a family dealing with a cancer diagnosis and treatment. The safety issues, as you know, we've all heard, especially in the last week, about the AstraZeneca, about the clot issue, a rare event. I saw some questions about that coming in already. Anytime we have any sort of negative information about the vaccines, it gets out in the media and patients hear it. So nurses are often the ones who say, gee, you know, they're sitting there with the patient, getting them either ready for their treatment or hearing their concerns and have hours often. And they'll say, well, gee, I read about this or I heard about that. And so these safety issues keep bubbling up and they will continue to bubble up. And what we need to be is consistent in our messaging, whether it's about clots, whether it's about fertility issues is another one I've heard, or altering of DNA. I mean, there's a lot of issues here, much of it based on the fact that we did have a rather rapid development of these specific mRNA vaccines, but we have a long history, 17 years of bench history, working with mRNA vaccines, and luckily had that platform in place. So, you know, you try to use that messaging with people. This didn't just happen in 9 months. A lot of work, a lot of years happened before we actually had these vaccines. In terms of trust, the trust is really based on the messenger. And I would really recommend that oncologists and nurses are very much trusted messengers, and that we have to be up to date with our information when recommending vaccines to protect our patients, to protect their families, and to protect our staff. And some of these messaging needs to be specific to the person with cancer, because there are different considerations around timing with treatment and timing after treatment and the type of diagnosis. So I'm going to pause there.
Thank you. Tony, I know you had some insight into the whole blood clot issue that AstraZeneca, that was associated with the AstraZeneca vaccine, and that's been out there in the press. It was halted in terms of the vaccination program in Europe and then restarted again. What are your thoughts about this?
Right. I support exactly what Lisa said, is that what the media posts, and that's what the public perceive, versus what is the real scientific information. So in the public, they got the media say so-and-so get vaccine, 3 days later they die. So they don't usually think of the cause and effect, and they do not really usually correlated to what is a normal incident of the event in the society anyway. Sometimes they say that I got a vaccine and then a week later I got pregnant. Are you going to put the vaccine accountable for your pregnancy? So people don't think like that. So on the other hand, you really have to go through your data. So there are two sets of data. One is from the recent US randomized study. They actually, about 30,000 people involved, 2-to-1 randomization. And they looked at the balance of their information in terms of their clotting problem. They are actually quite similar between the two groups. And also there is some retrospective data, the real world data from UK, the incidence of the thrombosis is not too much different from what is the expected incidence of the thrombosis in the society as a whole. So cause and effect, I think, is a very important message to put it out to the general public. Time is not the only cause and effective factor we need to look into.
Thank you. I think that really puts it into perspective. I've read some of that data, and it does seem that we're over-exaggerating it. I personally believe, I think we need to be monitoring patients prospectively and continue to collect data as a global community before we make any definitive conclusions. Daniel, next question's for you. There's been a question that's been posted, and specifically, this is an oncology-related forum. Where in the priority list do you see cancer patients who are actually being treated currently be in the priority list? Because they don't seem to be very high in that priority list in terms of getting access to the vaccines. Daniel, you're muted.
Yes, thank you, Dr. Dawood. So at this point in the United States, we've gone through the highest priority in terms of, healthcare workers, for example, and by May the 1st, it's thought that pretty much everyone above the age of 18 will have access to vaccine. So insofar as obviously patients with malignancies with cancer have, immunocompromised state, but also a lot of times there's some underlying comorbidities, as was referred to earlier, that puts them at risk. And then of course there's the issue of age. So I think all of those factors have to come into consideration in terms of the prioritization. But now I think in the United States, we're really at the point, in some states it's already reached the point where everyone above a certain age, even without comorbidities or immunocompromised states such as cancer, are eligible to get the vaccine.
Okay, thank you. Dr. Chite, you come to us all the way from Kenya, and I know we've had this discussion, but in terms of two questions for you. One, in terms of how prepared was Kenya for the vaccination program when it started? And secondly, Israel has been at the forefront in terms of being able to vaccinate its population really, really well by including patients with comorbid conditions, taking people who are above the age of 60 and making sure that all those healthcare workers are vaccinated. What sort of programs are you guys instituting in terms of the criteria for vaccinations? Professor Chite? I think he may.
Yeah, thank you so much.
Yes.
Yeah, thank you so much. I hope you can hear me. Yeah, thank
Yes.
you. With this COVID, we've actually just been learning on the go, like most governments anyways, and even healthcare professionals just getting more information and bombarded with new information daily. So when we got the vaccine from the COVAX facility that is actually doing some, especially AstraZeneca in various countries in Africa, beginning of March. And I think what happened was that we did not really have a very well-trained and sensitized healthcare professionals on the ground initially, so that when the vaccine came, you could actually have the vaccine has already been delivered in various health facilities, but there is no one coming to receive this vaccine. Although the government had already made the prioritization list of who needs to be vaccinated first. So initially they prioritized healthcare professionals and then some public health officials. But now they've actually expanded that to increase to people with comorbid conditions who are above the age of 58. And so those ones are also getting vaccinated. So I've seen over the last 2 weeks, a lot of queues in various vaccination spots to receive this AstraZeneca COVID vaccine. Now, in terms of healthcare professionals, the uptake has actually initially was a little slow. And I think it's just because the sensitization needed to have happened. And it's not just over one day, over a long period of time, because you expect these healthcare professionals to be the ones actually advising and counseling their patients and other citizens on these vaccines. So I think although the process was slow at start, now there's quite a bit of ramp up. And I see in various centers a number of people going to receive it.
Tony, maybe you can give us insight into the Asian perspective here. When I look at the stats online, Israel, USA, UK, UAE, where I come from, are doing very well in terms of being able to vaccinate a large proportion of the population. Asia seems to be lagging behind a little bit. Why do you think that is?
I think there's a couple of reasons. Number one, fortunately, our infection incident is not that high. Like for example, in Hong Kong past week, every day it was single-digit number. So the threat is not as much. And then on the other hand, there is all kind of so-called rumor about toxicity. Then Asians tend to have a way of saying, maybe I let somebody do it first. That is a very common mentality. But when this let someone do it first mentality proliferate, then no one's going to do it. So in Hong Kong, you know, that we had started a vaccine about a month ago, and now we had approximately 400,000 people, which is only 5% of population. It's relatively slow. And then there are multiple centers, all well set up with good personnel, well supported, free of charge, but still, it is still on the slow. I think that let somebody do it first type of mentality is the one that hindering the process.
Okay. Renata, you come to us all the way from Germany, and you're the president of the German Breast Cancer Association. Can you give us insight into how Germany and maybe even Europe is addressing the question about vaccinating patients with cancer, both with a current history of cancer where they're actively being treated and also a past history of cancer? You're muted, Renata. You need to unmute yourself.
Sorry, I thought I did. Thank you very much for this question. I think most parts of Europe are far behind than to other countries in the world with vaccination. But basically, patients with a history of cancer, they can be usually get the vaccine without a problem, unless there are other reasons. And patients under treatment, I mean, it depends on the kind of treatment, but in general, they, as far as it's suggested here, they can be vaccinated. So, but still there are some patients that are hesitant that it might interfere with their actual treatment, or it might have more side effects because of their treatment and so on. But I think that's something the patient has to talk to with the physician that is treating her or him.
Thank you. Professor Najwa, we have a question from a pediatric oncologist in Portugal. The question is, should families of children with cancer be, who are on treatment be considered also a priority? You're muted, Professor Najwa.
Well, from my viewpoint, frankly, I would love to prioritize them. However, that said, at the present time, every place has to know their own population, and please keep in mind that the amount of vaccine available is not very widespread in many countries where you have to keep on waiting for shipments and so on. So sadly, it makes a lot of sense that in fact they should be prioritized. However, you really cannot give them priority when you may have an 80-year-old diabetic or a heart patient. So frankly, it is very difficult to decide. However, I think this kind of issue will become important once you have sufficient amount of vaccine. Once you have sufficient amount of vaccine to cover what the groups we now think are prioritized, I think such patients, then such parents would in fact be a priority item.
So there is another question.
Yes.
There's another question for you. The question is, why did the pediatric trials not start as soon as the adult trials showed efficacy and safety? There was a lag time of about 4 to 6 months. What was the reason behind that?
Oh, frankly, I think, again, this COVID was very fast moving. I, as an infectious disease person, and I think many of you too felt this way, we were swamped with information. Let me just stop this. So we were really swamped with information that we had difficulty handling. And I think, I don't think really we were ready to think of making trials, especially when we were told that children are very, very low risk. Only did we start later to find out that in fact, there are some children who are at risk. So I don't think there is any real special reason, except that we were doing the job, trying as much as possible to handle it, at least from my viewpoint. I don't know if others have a different explanation.
Thank you. Tony, I'm wondering if you can tackle this question. As oncologists, and I know you're probably facing the same issue in your clinic, what is the best timing for vaccination for those patients on TKIs or immunotherapy or chemotherapy? What are you doing in your clinical practice?
Right. That's an excellent question. But then this excellent question can only be addressed if we do have the scientific data. So now we can only play by common sense. So that is the misfortunate part, because everybody's common sense can be a little bit different. So to me, TKI is not a problem because certainly it doesn't touch your immune system. So I don't think there is any specific concern with the TKI. Now, related to the immunotherapy, I think we have to look into what is the risk of the so-called immunosuppression with the particular chemotherapy. So ideally, just like anything else, that you want to have the best so-called myelofunction at that time. So usually it's before the next injection of that. So I probably would suggest a few days beforehand, so that you got a few days or immune system to kick in before you go on to your next chemotherapy. But again, this is common sense only. It's not real science that I can prove or disprove. Now, the immunotherapy is a bit of a problem because in a sense, it is affecting the PD-L1. But what does the PD-L1 play any role at all in the antiviral situation? I have no idea. I hope one of you can tell me whether the PD-L1 is related to the COVID-19. I have really no idea at all. Maybe Dr. Lucy, do you have any inside information in that regard?
Oh, I'm so embarrassed to say I don't, Dr. Mock. There's no data, which, as you said, and Dr. Nashua and others have said, it's the reality of the pandemic that physicians, we don't have the data that we usually have to be able to make informed decisions to help with our patients, because this is such
I'm glad I'm on the same boat as you.
Yes.
I think we're all sailing in that boat, and I completely agree with you. We need to use common sense. And one of the questions, Tony, is what about TKIs? Do you interrupt treatment to give the vaccination, or are you just plowing on with your TKIs?
First of all, it's kind of silly. Most of the TKI have rather long half-life, about 26 to 28 hours. If you want to stop, you just stop 5 days. And then you just say that, is it worth your while to do that? But while that is unknown. And to me, the TKI is a tyrosine kinase, very specific in the receptor level. And then to my best understanding, that none of the white cell have the EGFR or ALK receptor. So I don't think the receptor, I don't think it's going to tackle the immune system in any significant manner. So I cannot think of any reason to stop TKI personally.
Okay. Dr. Lucy, let me come back to you. Maybe you can answer this question. We're seeing a lot of variants emerge with the COVID-19 virus. So the first question is, will these existing vaccines cover those variants? And if not, should we be thinking about booster vaccinations for patients who have already had the basic first and second dose?
Yes, so this is a very timely question, as we are all aware around the world. And again, we lack the data that we want to have and that we really need. But the virus isn't sleeping. The virus never sleeps, only humans sleep. So while all of the vaccines in the world now, whether they're from China or Europe or Russia or the Americas, they all use the initial virus from Wuhan in December of 2019. The sequence of that virus. Meanwhile, the virus has continued to mutate as it's infected so many people around the world. And in some cases, it's created these variants of concern, of which, to my knowledge, there's at least 5, including 2 in the United States recently, one from California, first recognized in California, and the other first recognized in the New York City area. But others that we're familiar with, like the B1351, the B1117, and the P1 variants. So it's to me, the most important source of information is actual vaccine clinical trials in countries or parts of the world where the variants are actually being transmitted. We don't always have that kind of information. Instead, we have laboratory experiments, which I think are second best, and they're fine if that's all we have. So for me, the bottom line is that we have to make the best decisions we can in the absence of sufficient data. And so there's two things that I want to mention that are objective data, if you will. One is that at least one company, Moderna, earlier this month on March 10th, began a very small clinical trial with what I'd call a second generation vaccine. In other words, they used the variant B1351 that was first identified by the excellent scientists in South Africa, some generational colleagues that I worked in South Africa in 79, 82, and other times. So they're doing a wonderful scientific job there in South Africa. So Moderna used this B1351 variant in their vaccine. So to me, this is a proof of concept that we should be concerned about our, what I would call first generation vaccines, protecting as well against variants as they do against the non-variants or against some variants like the B117 first found in the UK, that the current vaccines seem to be working very well against. The second thing I just want to mention briefly, because it's a fact and I'm not endorsing or not endorsing myself, is that as you all know, recently the government of South Africa chose not to use the AstraZeneca vaccine, but instead to use the Johnson & Johnson vaccine because of, in my opinion, some data where there was a study in South Africa during their second wave with this variant of the AstraZeneca vaccine. And in my view, the sample size was too small to make any conclusions about whether the AstraZeneca vaccine protected against severe disease, because they didn't have severe disease in the placebo group or in the vaccine group. But the protection against infection and even mild disease was sharply decreased on the part of the AstraZeneca vaccine against the variant B1351. And that was much less so the case with the Johnson & Johnson vaccine. So those are just the two objective facts that I think are worth bearing in mind. But personally, I think that there will be more what I'd call second generation vaccines that incorporate one or even two or possibly three different strains, if you will, or variants of this virus. Somewhat analogous, but not strictly analogous to the influenza vaccines that contain several different strains of influenza each year.
Absolutely, and I think, go ahead.
One follow-up question.
Yes.
When you say the variant, I just want to clarify that actually we're talking about the change in the protein on the spike protein. Is it always referred to spike protein, or are we actually referring to other protein particle related to the shell of the virus?
So I agree with you, Dr. Mock. It's usually we focus on the spike protein, but in several of the variants of concern, there are some deletions as well as mutations in other parts of the virus, but primarily we've been focusing on the spike protein. Again, it's not only mutations, but sometimes deletions, which we think can confer the change in the phenotype in terms of more transmissibility or severity or other clinically and epidemiologically important manifestations. And evading antibodies, that seems to be very important. There's a single monoclonal antibody in the United States last week that the U.S. Health and Human Services said it will no longer basically be made available because multiple variants, including ones first found in California and in New York, are resistant to that single monoclonal when it's used, by itself. And so now we're favoring combinations or cocktails of monoclonals.
Okay.
I hope that's not the one that Donald Trump had used.
I'm not saying anything.
But I think the message that at least I get out of all this is that it doesn't matter which vaccine you're getting. It doesn't matter if we're covering the mutant or mutation or not. I think everyone needs to be getting those vaccines that are out there to reduce the severity of the current existing COVID-19 exposures that we are all at risk for. And I think that should be the basic message. What do you think, Dr. Lucy?
I certainly agree. That's the most important central message.
So, Professor Najwa, I hope you will take this question. You're muted. There's a question that's come to us all the way from Canada. Apparently, there's several provinces that have extended the interval between doses of the two of the vaccinations to almost 16 weeks. How do we answer questions from cancer patients when we know that they may lose protection after 16 weeks? I've seen so many different dosing schedules that have been outside clinical trial protocol. How do we address this issue?
Well, I think, frankly, they're trying to do that in order to maximize the benefit. Maybe that's what they're after. So possibly, while they want to do that, in all honesty, I think very high-risk people like cancer patients would not be people that I would consider really willing to live with that risk. In all honesty, I think it makes sense if you have a normal population and above 60% who is really okay. Sorry, if you may be hearing my little dog, she is very naughty. Just ignore her, please. So basically, but for now, I think for cancer patients, I will make sure they take it at the right time. But patients who are in a good shape, above 60, but they don't have any other risk factor, you may want to delay in order to maximize the benefit. As I said, the provision of the vaccine itself is a major issue. And that's why vaccination is a major thing to consider. And where is the vaccine if we are going to talk about vaccination? So really, it makes a lot of sense to do that, but not for cancer patients. I wouldn't do it for cancer patients.
So
Can I
Lisa,
answer one conspiracy question? There's so much
Yes.
variation on this schedule. How much of it is political? In a way that if they cannot deliver it, they put out story to say that, oh, you know, this is okay to do 6 week, 4 week. but where's the science? I mean, none of us have the science, but then that the government, as if it is the dogma or truth, that you can do it in 4 weeks, 6 weeks, 9 weeks, 12 weeks. So I don't know. I mean, it's just an open question, a little bit of conspiracy theory.
Yeah. Well, for me, just to answer, I'm not so sure it is conspiracy theory as much as you're trying to answer too many customers at the same time. This really is an unusual organism. And I've been giving advice on vaccines almost all my life, beyond 30 years, where we took fantastic amount of pressure on polio eradication and so on, and measles. We controlled everything. But this organism, because we did not know enough, this is the first thing. And it's the first time that we are faced with the fact that it is the older people who are going to be the major consumers of this vaccine. In fact, if you think of it, this is the one vaccine in our lifetime that is mainly after adults. We are used to giving it to little kids who are very obedient, who take it, mama brings them. So this really are challenges for us this time. I don't think it's really a conspiracy as much as really we are swamped with things we cannot answer. That's the way I feel. I don't like conspiracy. You can do nothing about it. This is how I feel.
So shifting gears a little bit, Renata, if I could address a question that's actually been a burning question in my mind, and like I said, you're part of the German Breast Cancer Association. What sort of protocols are you guys putting in place for patients that are going to be enrolled in clinical trials in the future in terms of the COVID vaccination? Is there going to be a mandate, or are you just going to encourage patients who have cancer who are going to be enrolled in these trials? I know you're part also of the metastatic breast cancer group as well. What's the policy going to be at your end?
As far as I know, it's everybody. It's suggested that they get the vaccination before they enter the trial, but I don't know. I think they can be vaccinated even afterwards, because I mean, otherwise they will opt out of the trial, and that's not what we want. So I think if it's reasonable, they will be vaccinated even on trial.
But there will not be a mandate for it. They won't be.
As far as I know, no.
Okay. Lisa, yes, you have something. You raise your hand.
Yes, we had a discussion this week, Dr. Daywood, about would patients be excluded from trials if they did receive the COVID vaccine while they were in it. And there was some FDA accommodations that recently came out that said that would not exclude patients from the trial or have them leave the trial because they had a COVID vaccination.
Okay. Lisa, while I have you online, if you can unmute yourself, There's been a lot of information out there in terms of the COVID-19 vaccine. A lot of it is sometimes very difficult to understand, especially for patients. And digging out that information has also been very difficult. What do you think about the fact that we should also be focusing on getting simplistic information out there to our patients, especially those with cancer, so that they can come in and be well informed prior to vaccinations?
Excellent question. As nurses being very trusted healthcare providers, and I'd mentioned the trusted messenger as being important to get over some of the hesitancy and skepticism that we've seen about the vaccines, that it's important not only do we have those conversations, but we follow it up with some sort of written materials as well, so people have something to read without saying just go, in our country, say go to the CDC website, which is a massive number of clicks to get to get some information. Are there other ways that we can be targeting our information for people with cancer, getting particular treatments? And yes, as Dr. Mock said, we don't have the science here, but we do have some common sense for our patients, and we can make recommendations as trusted messengers to increase the uptake of COVID vaccination in people with cancer who we know are at higher risk from our registries.
Dr. Chitte, maybe you can provide some insight into how physicians and nurses at your end are actually conversing with their patients regarding the side effects that are associated with the vaccines, especially in cancer patients. I know you're a hematologist. You're probably dealing with patients who are even more immunosuppressed than us humble medical oncologists. So how are you dealing with this?
So thank you so much for that question. So there are several things to this. One of them is that it actually depends also on the stage at which the patient you are treating. So, there are those patients who are receiving high dose chemotherapy. There are patients who are going on to bone marrow transplant. And so it depends because, this vaccine is meant to elicit some humoral and cellular, response. And so if somebody really is markedly immunosuppressed, although there may be some efficacy for the vaccine, it's not really as high. However, we are still encouraging them to get. So for somebody who is going into high dose chemotherapy, we usually recommend to get this vaccine 2 weeks prior to getting into this high dose treatment. And as we've said before, and as Tony has mentioned, a lot of these things is not from any clinical trial. Actually, we are just, using our best logic, considering what we know in response to various vaccines in the past, especially in the hematological malignancy patients. And if you look at even for the sickle cell patients, quite a number of them would be asplenic, especially those who've been having a lot of crisis over the years. And so we don't actually know how much response they would yield with this vaccine, but we are prioritizing those patients as well. And for those who have gotten transplant, like bone marrow transplant, especially autologous stem cell transplant, then we are recommending after 6 months of the transplant, because at that time you are actually expecting that their bone marrow has recovered and they are able to create an immune response to this. However, those who've undergone allogeneic transplant, of course, it may be a little bit longer. The good news with this is that one, we keep telling our patients that, listen, when you are taking the vaccine, and I really like what Lucy mentioned when he was his presentation, that says you're not only taking it for yourself, you're also taking it for the others. And so when you are talking about healthcare professionals getting this vaccine, you're actually looking at, there's an answer to a question we don't know. So when the people who've been vaccinated are asymptomatic, how much are they transmissible to the population that is around them? So we keep on telling them, even after the vaccine, we still expect you to do all the things we've been doing, social distancing, sanitization, hand sanitization, and avoiding overcrowding and all those things. You still have to continue doing, because as we continue rolling out this vaccine, we will continue learning a lot more about what we need to carve back or go forward with. But at the moment, we just encourage them, please take it. And then for Kenya, some people have been saying, oh, we are getting an inferior vaccine. We are getting AstraZeneca vaccine, while other places like in the US, they are getting Pfizer, Moderna, and all this cool stuff that is 95% efficacy. And what we've been telling them is this: if you look at the data, even on the AstraZeneca vaccine, remember, it's actually protective of the severe forms of COVID. And this is going on to your ventilator, going into hospitalization, and even death. And so I look at that as a very important thing. And I think somebody mentioned, if it was just like the flu, which all of us recover from very quickly, we would not be making all this noise about it. However, we know the devastating effects of this COVID itself, and especially to our cancer patients, both the ones who are on immunosuppressive therapy and also those who already have some immune dysfunction because of their disease, like CLL, for instance.
So I want you to be online, and I'm going to ask Tony to chip in over here. There's a very interesting question from someone in Kenya, and Tony, you've been out there, you've seen what's happening politically, at least. So the question is on the COVAX vaccine. How can the global oncology community ensure that COVAX vaccines achieves its intended primary objective, that means equitable access to ensure supply to low and middle income countries, when we've seen high income countries holding back large supplies? How can we ensure that everyone is receiving the vaccine? Do you have a simple answer, Tony?
Obviously, I don't. But I think there's a couple of principles. First of all, the pricing. Whether the company are there to intend to make a profit, or are they making to the supply without making a intention of a profit. So I have to declare my conflict interest with AstraZeneca of my involvement of the company. However, when the decision was made, that we're going to partner with Oxford Jenner Institute, is that we are not going to make a profit. So that probably will make the price most affordable for most countries around the world. So I think the first is about the intention of the production. So after that, that will be up to the plane is the provision, the vaccination process. Now that is huge. That's really beyond me. Maybe I will have a vaccination expert to just say, what does it take to entail a fair program? I think it takes a lot more than just the government to do that. So how does it happen? I think really beyond me as a humble oncologist, listening to the real expert.
Professor Lucy?
Yeah, I wouldn't say that I fit the description of Dr. Mark as far as the expert and everything about vaccines, but I certainly agree with him that cost is a central important issue. And I think that that's been recognized by most people in the world, including by the World Health Organization, the COVAX facility. I'm not on any boards, I'll just say that, and I don't have any stocks or investment in any companies at all, vaccines or otherwise. But there's been discussion, as I'm sure you're aware of intellectual property rights or patents, and also just the involvement or lack of involvement of the United States during the previous presidential administration, when it was announced by a former president of the United States that the US would pull out of the World Health Organization. Fortunately, that was a 12-month process and it didn't occur. And now the new president, President Biden, has said from his first day in office that the US will not only continue in the World Health Organization, but provide I think a sizable amount of money to WHO, the COVAX facility in particular, to make vaccines more available around the world. That said, there's been very, what should I say, energetic discussion just in the past couple of weeks about whether the United States will soon have more vaccine than they can use or than they need for our US population. It's not the case today, but it could be soon. In which case, why hasn't the United States made available some vaccine to the WHO COVAX or to other countries? I think that's a very important question that has to be answered and resolved in the direction of making vaccines available that the US has already purchased. And that could include the AstraZeneca vaccine as well as others.
So while I have you online, can I just summarize two questions that have come in about the AstraZeneca vaccine? One, in terms of blood clots, should we be considering using aspirin or some form of anticoagulant in these patients? And should we be worried about the protein hypersensitivity that could happen with the COVID-19 vaccine, especially with the AstraZeneca vaccine? This is a question from Kenya.
Oh, I think I would have to defer to Dr. Mock, who's more familiar with the AstraZeneca vaccine than I am. But again, I think there's the issue about, well, what are the data to say that there's an increased risk of clotting? In the US study of AstraZeneca, over 30,000 people randomized 2-to-1, so about 20,000 got the vaccine. There was no increased clotting risk identified. But again, I'll turn it back to Tony.
I don't have any more data to use prophylaxis, because when there's no, in the randomized study, there's no increased incident. How can you justify on the prophylaxis based on just the so-called the reported data that is out in the media? I can see a hand raised from the expert.
Oh. Yes, Najwa.
Yeah, I wanted to ask, even though we don't want to give prophylaxis and so on, should we ask before we give the AstraZeneca vaccine, if anybody had a history of clot, not to receive it or to receive a different vaccine?
Now, all of a sudden, I become the AC vaccine. I'm not. Okay? I'm an oncologist.
Maybe Daniel will answer.
So maybe I could just take you on to a second question, Tony. In as your humble role as a medical oncologist, amongst all the vaccines that are out there, we don't have the data because they weren't cancer patients who were on treatment that were actually enrolled in these trials. Do you believe any one of these vaccines may be more immunogenic or might mount a better immune response amongst our patients with cancer? Or do you think as of now, there's simply no data and we have to consider it equivalent?
So we had a chat last night together in this with Dan. Dan had made a very good point. Is all these trials are done in different places, different population, different infection risks, and then whatever data they generate from this particular environment, you cannot compare with the data that generate from the, one other study in one other environment. So I think it's totally wrong to compare one data set with another data set and just say that one is looking better than the other. So the simplistic 90% versus 70% is not a fair way scientifically to compare. So unless we do a head-to-head randomization, just what like we oncologists love to do, we are not going to conclude. But I think it's an important message to the public is that any vaccine is good. Any vaccine is better than no vaccine.
Absolutely.
Once you start compare, it's risky to say that, oh, you got a better one than I do. I'm not going to take it. So it's a wrong mentality. I think we really have to spread the message is that as long as the vaccine is safe, anyone is beneficial.
Okay. Renata, I have actually a question here from a patient. So I'm just going to, from, an advocate's perspective, she asks the question, I just finished radiotherapy from endometrial cancer. I have lots of allergy and I have sleep apnea. What kind of vaccine is good for me? What is the message that, from the German society that you would give out to patients who ask that question?
I certainly would ask her to tell the physician or at the when she goes to the vaccination center or wherever she goes, and tell them about the allergies, and maybe if she knows what allergies she has, to point out which they are, because there might be something in the vaccine that is explicitly where she has the allergies. Unless nobody knows, probably it's important that the physician or the nurse knows about it and then can take care of in case there is an allergic reaction.
So we just have a couple of more minutes before we end this, and there's so many cool questions that are coming in, and unfortunately we won't be able to answer all of them. But in the last couple of minutes, I'd really like to go around the panel and really get one take-home message that you'd like people to know out there. Lisa, we'll start with you. You're muted.
So my I have a two-part message. It's singular.
Okay. All right.
One is get vaccinated. And number two is don't stop what you're doing. Continue masking, social distancing, hand washing. Even if you're in a country like the US right now, where we have a very substantial proportion of adults vaccinated, we are not done yet. So keep doing what you're doing. A vaccine does not make you gold-plated. You can still get it. You can still transfer it. Keep wearing your mask, keep going, and get vaccinated.
Thank you. Professor Chitte.
Yeah, so in addition to what Lisa said, so for me, I would say the best vaccine for anybody is what has already been authorized, even if it's emergency use authorization in your country, and what is available to you. Don't wait until you say, I'll get Moderna or another vaccine. just discuss with your healthcare providers, look at some of the side effect profile and all the information. Once you get that information, please take this vaccine so that we can really end this pandemic at some point. Thank you.
Tony.
Very quickly, vaccination for COVID-19 is a social responsibility. It's not just for yourself. This is for the society to move forward. I think it's our responsibility, but we just have to exercise the best judgment on the best timing and the best situation.
Renata?
Okay. So I agree with everything that has been said so far. For me, there are 2 points. One is vaccination is not only about prevention of infection, but also prevention of serious illness.
Absolutely.
And the second one is what we haven't mentioned yet. Be aware and tell your doctor if you were vaccinated and you go for an exam, so they know that your lymph nodes might be enlarged because of your vaccination, and that might last up to 4 weeks. So tell them, let them know that you don't get any kind of wrong result.
Absolutely. Professor Najwa.
Well, I would like to just simply reiterate what was already said, because many people do continue to be convinced that I want to wait for Pfizer, I want to wait for Moderna. As was said, take anything that is given to you. It is a must. Not only that, frequently people keep on saying, what are the side effects? I tell them, please, if you see a car coming your direction about to hit you, you run away. And this is the same. We're not giving you a vaccine because we'd like to experiment on you for the vaccine. This is a serious disease. And I think people should know it's a serious illness. It's not a joke. So take the vaccine and stop quibbling about what will it do to me. And I think this is not yet discussed enough.
So, Professor Lucy, before you make a last comment, I'm going to give you the last question that's actually come in here. So for someone who had a first dose of, say, for example, the Pfizer vaccine and then got tested positive on week 3, and then they have to delay getting their vaccine. One, should they be getting their vaccine, the second dose, after they've recovered, or should they just restart the whole process again?
Yes, I would say don't restart the process again. In fact, since you've been infected and then recovered, you have an immune response from the infection, you have an immune response from the first dose. So don't start over, and talk to your doctor about when to get the second vaccination. In the States, often it's said to wait for approximately 3 months or 90 days after an infection.
And your last comment to everyone, that key take-home message you'd like everyone to know.
Get the COVID vaccine that's available to you wherever you are in the world, both for yourself to protect against serious disease, hospitalization, ventilators, possible death, and also to protect the people that you love who are around you.
So I'd like to thank all our panelists today. We've had so many questions that have come in. We haven't been able to answer all of them. It's been such a rich discussion, but I'd like to echo what everyone has very clearly stated, that we need everyone to go out there and vaccinate. It doesn't matter whether it's the Chinese vaccine, Pfizer, Moderna, or something new that pops out there. It does reduce the risk of severity of COVID if you get it. It also protects other people in your group, in your society. Our patients with cancer who are actively being treated should also be getting the vaccine. That's the key message here today. Speak to your physicians or your oncologist and the nurses that you're working with to find out the ideal time as to when you need to take that vaccine. I think as a global community, we will need to pool our data together, as we need to get more and more information and more data that we will collect prospectively, observing our patients with cancer who are getting that vaccine. And that's how we're going to answer so many of those questions that have come in today. So thank you very much. And thank you to ASCO and the IDSA Society and the German Breast Cancer Association and our group from Hong Kong and Kenya and USA. They've all pulled together to be able to bring you this webinar. Thank you very much.
Thank you. Thank you.